Good afternoon, everyone. I think it's time that we get started. I'm sorry for the delay. I'd like to welcome all of you again to part 2 of the 2018 CANIBD program. Before we get started, I just had a couple housekeeping items to discuss. As you'll notice, there's a gentleman at the back with a video camera. He is videoing the speaker's presentations today. I've been assured that it will be focused on the speaker only. It will be placed on our CANIBD members only portion of the website so that you can review it at a later date. If you have, I think an email will be going around to everyone. If there's any concerns about having the video, please reply to that email. The other important information is the evaluations. You should be receiving an email from the organizing group with today's as well as last evening's evaluations. It's really, really critical you complete those because we base this program on your feedback from last year's. I would like to take a brief moment to really send a warm thank you and welcome our sponsors that are here with us today. Without your generous contribution to CANIBD, we certainly would not all be here today. I'd like to thank Merck, AbbVie, Janssen, and Takeda for their generous support. I would also like to thank CSGNA and Crohn's Colitis Canada as being wonderful partners in helping us develop CANIBD and help us move forward. Also, I know they're not in the room, but I'm hoping that maybe on your way out today, you could give a big thank you to Catherine and Lois and their team. They have done an incredible job of organizing us through the whole year. It is a real big job and a labor of love, and we certainly couldn't do it without them. There was one other housekeeping item I was going to do, but I don't see the person here, so maybe I'll wait till the next break to do that. So, moving forward, I'd like to welcome Brenda O'Connor to the podium to introduce our first speaker. Let me just... Sorry, I'm just trying... Yes. My finger doesn't want to work. Right there. Number 2. Silverberg? Yes. Silverberg. Okay. Very glad you're here.
Yeah, me too. Don't really knew that. Okay, thank you, Jen. It gives me great pleasure to introduce my colleague from Mount Sinai and my friend for a long, long time now. Okay, Mark Silverberg. Dr. Silverberg completed his internal medicine and gastroenterology training at the University of Toronto in 1997. He then completed a PhD studying the genetics of inflammatory bowel disease in 2002 at Mount Sinai's Research Institute. He's currently a professor in the Department of Medicine at the University of Toronto, and his research program is funded by grants from the National Institute of Diabetes and Digestive and Kidney Diseases, the Canadian Institutes of Health Research, and Crohn's and Colitis Canada. His lab, which is pretty huge now, is focused on genetic and microbial contributors to the pathogenesis of IBD and to identify biomarkers relevant to its clinical course. So we tapped onto that this morning. He's made significant contributions to the discovery of genes and related to IBD, as well as being a major contributor to the field of phenomics and classification of IBD, which is the Montreal classification. So it gives me great pleasure. He's the international organizer of the study of inflammatory bowel disease, chair of the Scientific and Medical Council of Crohn's and Colitis, and past chair of the AGA Council for IBD. Okay, thank you, my dear. I can go on.
Somebody's planning their way out of here as quickly as possible. How do I escape? Thanks, Brenda. You could have stopped at friend and colleague. That was enough. So it's a pleasure to speak to this audience because I think you guys are the ones that are really doing the hard work and in talking about this type of thing and what therapies work and how they respond, and dealing with the tears and the scared patients that don't know what to do. And we usually just throw a whole bunch of options at them and then send them away to one of you to do all the hard stuff. So I'll try to give you my perspective. There's a bit of data, but some of it actually is just more my opinion and thoughts after doing this for 20 years. A lot of conflicts, so take that into account and maybe don't believe anything I say. So these are the objectives. It's a lot to cover, and I hope I don't sort of whiz through this too quickly, but we've left a half an hour at the end to have Q&A so we can get into more details and specific issues. So to me, the whole issue really around talking about therapy and safety is risk-benefit balance. And I really believe that every choice that our patients make has a benefit, a potential benefit, and a potential risk. And that includes the choice of not making a choice and not going on a therapy at all, or choosing to take, let's say, a naturopathic approach. People have a tendency to want to think that Western medicine is mostly bad, and that maybe a naturopathic approach can only be good and not harmful. And I always think it's helpful to remind people about that the risks of taking an approach that maybe doesn't have evidence or doesn't seem to work is the downside of the natural history of the disease. And when people are often very nervous about a side effect that we know is fairly uncommon but potentially serious, I try to weigh that against the natural history data that we have of the disease, that they're 20% likely to need surgery or 30% likely to end up with a perianal abscess or need a stoma. So it's all about that type of thing. And I've learned over the years that a lot of what goes into these discussions is a belief system. It's not about they're not educated. It's not about that you haven't explained it well enough. It's that patients, many of them have an internal belief system, and it often is from a very young age that they've sort of grown up with a certain belief about treatments, about drugs, about natural approaches. And it's really hard to change that. And sometimes it's more supporting the patient through their course till you get them to decide for themselves. And at the end of the day, that's what I teach our residents and fellows, is that never force a patient to make a choice, never push them if they don't want to do it. You have to guide the patient and let them come to the decision themselves. And sometimes it involves letting people get quite ill, unfortunately, until they're ready to make those decisions. But that's usually the way to go. And I've learned in our center that I never tell the patient what to do. When they turn and say, well, what would you do? I never say what I would do. I say, well, I don't know what I would do because I'm not in that situation. But, you have to make the choice that feels right for you. So that's my little introduction. And now I've been asked to cover all therapies, which is nice. Actually, we're not just talking about biologics. So I think it's important to remember that all of our therapies have pros and cons starting right from the beginning. So I probably won't be able to get through everything, but I'll try to give some categories and overviews. So first category of medications, and by the way, we could have also talked all about the naturopathic things that are hot, like cannabis, which that's going on now. Probably some of you would rather be at that and hear what's going on there, but we can talk about those things during the Q&A. So 5-ASA drugs, mesalamines, there's a lot of options within that category. Sulphasalazine was the original one, still a really useful therapy. We shouldn't, dismiss things just because they're old. I do still prescribe it. As a category, they're generally safe, and they generally work really well for ulcerative colitis in particular. Many patients are fine on 5-ASA and don't need anything else. A big issue with 5-ASAs is the pill burden. You have to take a lot of pills to get an effective dose, so it's a daily reminder that I'm ill. They're big pills, they're hard to swallow. Sulphasalazine, one downside of it is that it does have a sulfa antibiotic moiety attached to the mesalamine, so it can cause allergic reactions and a little more GI intolerance than standard mesalamine drugs. The side effects, there are side effects. They're rare, but everybody who treats IBD has seen these. So probably the more common one is paradoxical secretory diarrhea. So not everybody is aware that that happens, and sometimes they think the patients are, being functional or making it up, but it's pretty typical. They take it, whether it's oral or topical, and within 24, 40 hours, they start having worsening watery diarrhea. It's usually watery and not bloody. But that's pretty typical, and when you stop it, it goes away. And if you're not sure if it was real, you can re-challenge them in a week or two, and usually the exact same thing happens. So I probably have seen this 15 or 20 times, pretty classic, repeated testing confirming that it was a true reaction. And then there's all the others I've listed are quite rare, but I've seen them all. So it can cause these reactions, immune reactions in various organs, pericarditis, so they present often with chest pain or shortness of breath, pancreatitis, you're familiar with the symptoms of that, and pneumonitis. So it seems like there's just these epithelial kind of reactions that are paradoxical that we can't really explain. Interstitial nephritis is a kidney issue that is rare also, but I have 2 patients on dialysis from 5-ASA from not recognizing that they had to monitor their creatinine. And so when we think of this category as very safe, it is, but those are big disasters, obviously. So the main thing is to monitor the creatinine at least once a year when they're on therapy. And if you see the creatinine start rising, you have to think about that. So a lot of patients on 5-ASA don't get any monitoring. They don't go for follow-up because they are well and they think they're on basically simple therapy. So chronic 5-ASA still requires blood work at least once a year, and in particular the creatinine, which again sometimes isn't even done because it's not always on the radar of gastroenterologists to check that. So I've seen a few bad outcomes from that, so you've got to be aware of that. Antibiotics. So we at Sinai do use a lot of antibiotics. Other centers don't use a lot. There's not a ton of evidence base to using them, with the exception of pouchitis and perianal fistulas and abscesses. But a lot of us still use them when we're sort of in trouble in certain situations. These are the most common ones, although you may see people on vancomycin or cefuroxime and others, but these are the most common ones. So Cipro is generally well tolerated. The concern with long-term use is tendinopathy and tendon ruptures, so that's not as common as we used to think it was, but have seen it. So long-term use is the problem. Short-term is generally not a problem, but older patients are particularly at risk, like over 60, 70, especially if they're still a little bit physically active. They can rupture Achilles tendons. Metronidazole, also flagyl, we use a lot of that. The most common side effect are more just GI intolerance or so-called hangover reaction if they drink a lot of alcohol with it. It's not a dangerous thing, it's just a nuisance for them. They often get a metallic taste on their tongue when they eat, but again, not a serious side effect. The more serious thing is neuropathy. So I've seen people with permanent sort of numbness in their fingertips. They can get pins and needles sensation, tingling sensation. So typically that neuropathy is associated with higher doses. So the way I think we've used it more successfully is lower dose. So metronidazole, I tend to keep it at 750 milligrams per day or lower. If you keep it at a lower dose, like our chronic pouchitis patients, they do tend to tolerate it better, and I've not seen many side effects at the low doses. The ones I've seen are typically 1 gram and higher doses. So, and I can't translate that into pediatric, Karen, but all right, steroids. So steroids are the devil we know and the devil we it's sort of that drug that makes everybody better and everybody hates. So it's very useful, prednisone, but as you know, the problem is the real problems you get into are with chronic use. So I personally don't have a huge problem with prednisone. I'm not, it's not my sworn enemy. I think a lot of patients have very immediate and effective response to it. The key, though, is limited use. So if I have a patient with UC that is very sensitive to prednisone, and after 6 weeks they're better, and they don't need it again for 2 or 3 years, and then they need another course, I'm okay with that. Once in a while, short courses. But it's the ones that we've all seen, which are slowly disappearing. But historically, there were a lot of these patients that were on 10, 20, 30 milligrams per day for months and years. And once that happens, those patients are in real trouble. And some of the nastiest kind of side effects and complications I've seen have been in those patients. The first part of the side effects are more related to the acute short-term use. They're mostly nuisance side effects, but as you've probably all seen these patients who've had one short course of prednisone and had some of these cosmetic or mood changes, and they say, I'm never taking prednisone again, and that's perfectly fair if people have these. So the acne is very common, weight gain, stretch marks, striae on the skin, the moon face and Cushingoid type of appearance. And don't underestimate how badly people feel with the mood changes. So insomnia, depression, psychosis. I've seen it all, and sometimes we forget that it's steroid related. So in these patients, you've sometimes just given it to them once, and you're never going to use it again once you've seen what it does to them. So those can be problematic, but they're generally short-lived and generally go away when they're off the steroids. The other things are more related to chronic use in general, so increased risk of glucose intolerance, diabetes, high blood pressure, myopathies, cataracts, glaucoma, infection. People sometimes forget that steroids are the original immune suppressant, so there is an increased risk of infection with prednisone, and it does also actually predispose to recurrence of tuberculosis, latent tuberculosis. We don't do TB testing and all that because there's no companies reminding us, but you can get reactivation of TB on high-dose steroids. Avascular necrosis is rare, and not duration limited. It can happen after a few weeks on prednisone, but fortunately quite rare. And Addison's related to chronic use is very problematic. So steroids are, there's a whole long laundry list of side effects. Again, mainly chronicity in use, and mainly in patients who just won't switch to anything else because they're just used to taking it. It's cheap, it's simple, and for some people, they just don't want to let go of it. I think a big problem is when people come off steroids. This is where counseling is important. I always tell them when you're reducing your steroids, you're going to feel terrible. They feel weak, they're lethargic, and then they boost it back up again. And there is a bit of that rebound effect as they reduce steroids. So you just kind of have to coach them to and say, push through it. It's like, going to detox. It's, they have to just get through it. It takes a few weeks, and then they feel better once they're going to get through that period. A brief word about budesonide. So it's either Entocort or Cortiment. This is safer in the sense that it doesn't have as many of those systemic steroid side effects. It's first pass metabolism, which means the metabolites of the steroids are degraded in the liver, so there's less of it, of the systemically active product circulating. So it is effective in the sense of avoiding the steroid side effects, but it also isn't as potent as prednisone, so it doesn't have as much role as the as steroids. In general, I think it's safe. You have to be careful. Some patients end up on these chronically, and when they are on it chronically, you can start to see the steroid-related side effects as well. So just be careful about that. All right, immune suppressants. So azathioprine, 6-MP, Imuran, pyranethol, whatever you want to call it. The most common issues around that are the GI intolerance, just nausea, upset stomach. That does often go away, and if you start at a lower dose and sort of work up, people often get past that. But all these other things are the ones that are more problematic. So there is an increased risk of infection. Again, it's an immune suppressant. Those are the immune suppressants that we talk about. Especially viral infections is the most common. So HPV, EBV, CMV, chickenpox, warts, all the things that are virus associated tend to be the ones that are more problematic with this category of drugs. Pancreatitis is a classic. It probably occurs in about 2 to 3% of patients on these drugs, but you know about it pretty fast. They'll call you in a few days and be in a lot of pain and vomiting. But I have seen people not recognize that and keep taking it and getting sicker and sicker. Pancytopenia and bone marrow suppression is a big problem. You have to monitor blood work regularly. It's another one where it's easy for patients to forget when they're doing okay that they should have blood work. People vary between on the interval, whether it's every 2 months, 3 months, 4 months. Early on, you want to do it very regularly, like even weekly in the first month, and then I start spreading it out. And when people are stable, I usually say every 4 months is okay. So you're looking for the white blood cell count, platelets, hemoglobin. The TPMT test is more widely available in Canada, I think, now than it used to be. So that's a good screening test to predict at least a small number of patients that may have the profound bone marrow suppression from Azathioprine 6-MP. So if you have it accessible, you should probably do it along with all your initial vaccine discussions and pre-biologic workups that you might do early on when you first see a new diagnosis. Lymphoma is the big one. I'm going to show a slide separately on this. But lymphoma definitely occurs at a higher rate with this category of drugs. And I'll just show another slide on that in a minute. Methotrexate, we don't use it quite as much as maybe other groups because I find it poorly tolerated, but the nausea is more problematic to me than in the with the Azathioprine 6-MP. It is somewhat dose dependent, so the more you give, if you give 25 milligrams by injection weekly, you're going to see more of it than if you give 10 milligrams orally once a week. But I think the efficacy is also dose dependent. So you have to balance those. And otherwise, it's actually, if they get past that, there's not a lot of very serious side effects. It sounds like a scary drug when patients read about it and they see chemotherapy and they get very nervous. But actually, other than the GI intolerance, it's pretty uncommon to have serious side effects. There's no lymphoma risk, so that's a benefit. We used to do liver biopsies and worry about that, but that's almost never done anymore, and I've never seen a serious case of liver or lung scarring, but that's one of the reported side effects. So back to the lymphoma issue. So this is a study, there's a lot of data on this, and it is hard to show clearly what the risk is because it's rare. And there is a background risk of increased lymphoma in IBD de novo. So that's something to keep in mind, that any chronic inflammatory disease does have a slightly increased risk of lymphoma, rheumatoid arthritis as well. So it's hard sometimes to separate that background risk from the drug-related risk when it's such an uncommon outcome. You need huge studies and long-term follow-up and good control for various outcomes. But this was one that I thought was important for two reasons. One is it does show overall an increased risk of lymphoma 4.5 times the background risk. But what's important to show when you hear about these studies is the top half are referral-based studies. So it's like our center or McMaster, where patients are getting referred in for specialized care. They're sicker, more severe disease, more drugs. So they always show a higher risk than the true population-based studies like the ones on the lower half that are coming from all eligible patients. So, but there still is an increased risk even in population-based cohorts with azathioprine and 6-MP over the background risk. So it's rare. What I sort of say to patients is probably the risk is around 1 in 5,000 to 1 in 10,000 overall. And when you take these drugs, it could either double, triple, or quadruple. But remember that, always remind that the absolute risk is pretty low still. It's still 1 in 2,000, 1 in 3,000, 1 in 1,000. 1 in 1,000 doesn't seem that low for lymphoma, but you know, it's still rare compared to risks to their disease. So my overall kind of thoughts on azathioprine 6-MP methotrexate is I sort of look at them as useful more in this era as adjunctive therapy, often with biologics. I don't use a ton of it anymore as monotherapy, and I do think overall they're probably cumulatively the most dangerous drugs that we use. Still not terrible, but if you look at just the total side effect profile, they probably have the most side effects of all the therapies that we use. All right, now let's move into the biologics. I'm already running out of time, I think. So I'm going to try to do this a little quickly, but I think the important thing to know about clinical trials, this is a really useful slide, I think. So when you look at new drugs, because all the biologics, a lot of patients say this is new. How new is it? How long has it been on the market? What you have to remember is when a drug is launched, even though there's a lot of 1,000 patients in the randomized controlled trial, it's only really being used for a few years in a very tightly controlled patient population that's been screened for every possible bad thing that could happen to them, and they're all out of the study, which is like 10% of the patients that we see in real life. So I almost ignore completely safety. Whenever they say no safety signals in an induction or maintenance trial, great, okay, but I don't really care about that at that point in time. What you want to know is what happens after that, all the real world data, the registry trials and data, the real experiences that start coming out, and that's where you start seeing the side effects. That's where the reactivation of TB was seen, and the lymphoma risk, and all those sort of things start coming out in real life. So I sort of look at it as the initial clinical trials are like your kid getting their driver's license, and then after that they really learn how to drive. So when we have a drug that we first use, a brand new drug, you know it's safe, you know it's effective, but you really don't know what it's going to do in the real world, and then you need those years of experience to start to feel that. So let's cover anti-TNFs as a category. So I'm not really talking about efficacy here, so we're putting a bit more weight on the risks than the benefits, but I think overall anti-TNF drugs are the most effective drugs we have for IBD, and that's with all the new drugs coming. I'm not convinced, maybe Niraj will disagree, but I think my opinion is that still the best drugs we have, and all the fancy new things still are working to get up to the level of an anti-TNF. Having said that, there's a lot of side effects. They're generally, I think the risk-benefit profile is favoring anti-TNF because they work so well. But infection is the most common one. Roughly 5% of patients per year get serious infections, but they're very manageable. You can treat them. You don't have to stop the drug. And it is not usually a big issue. We'll talk a bit about malignancy in a minute. And I'm going to cover each of these maybe in a bit more with one slide each. So the infection risk, this is from the TREAT registry, which is a big long-term real-world sort of outcomes that look at side effects in real-world practice. So 6,000 patients in all different practice settings. And you could see that there is a slightly, just overall profile, there's a higher risk of infection, but there's different variables that modulate that. So disease severity is the biggest one that we often forget. Sicker patients are more likely to get infections. Patients in remission are less likely to get infections. You could see the infliximab risk here is 1.4 over controls that aren't treated with infliximab. But then when you start layering on different therapies, the risk starts going up. So in this one, immune suppressants was not quite statistically significant, but other studies do show that combinations of slightly more risk of infection. Steroids really ramp up the risk with the biologic, and then narcotics actually do the most. And I'm not even touching on narcotics, but that's for sure the most dangerous thing that we use just globally in terms of risk of death. So
Can I ask
why?
Yeah,
It's a great question.
People can kill you because you have but why?
There's a lot of reasons for that. Maybe we'll do it in the Q&A as a discussion. It's not like a cause of death because of heart attack. It's probably a marker of the global burden of all the issues that a patient on chronic narcotics has. But it's an absolutely clear signal across multiple studies. Again, serious infection risk with biologics is very manageable with biologic monotherapy. As soon as you start giving steroids and immune suppressants with the biologic, the infection risk goes up significantly. So whenever we are using Remicade, let's say, steroids, Azathioprine, all in the same patient, those are the ones that I lose a bit of sleep over. We do have to use those combinations a lot, but those are the ones you should worry about. Infliximab or adalimumab or golimumab monotherapy is generally really safe and well tolerated from an infection standpoint. As I said here, most common infections, most of the infections are bacterial. Concomitant drugs that you add on increase that risk a lot. How do you reduce the risk? So this is where you guys come in. I always counsel the patients to watch for fever and to make sure they let somebody know, whether it's a coordinator, PSP, nurse, physician. If they have a temperature over 38 degrees, they should see a doctor and not just lie around in bed. Treat infections appropriately with antibiotics. That doesn't mean they should take antibiotics every time they don't feel well, so you have to balance that a little bit. They need good healthcare assessments. I tell them to avoid narcotics completely, minimize the use of steroids and immune suppressants, and over age 60, the infection risk goes up significantly. So I start worrying about anti-TNF use in patients over age 60. Opportunistic infections, we've touched on these. TB in Canada, we don't have to worry quite as much about histo and coccidiomycosis, but we do see it from time to time. And I don't have time to go through all of these, so we'll just move on. Malignancy, most data do not support an increased risk of solid tumors with anti-TNF, and I think that's important. Patients all worry about cancer. It's probably their biggest risk. I think we can be very sure as you can be with something that's a rare outcome, that solid tumors are not a concern. But there are some unusual rare tumors that I sometimes wonder about. Lymphoma, again, it's actually not very clear that lymphoma is increased with anti-TNF use. Some studies have said yes, some no. Again, this is monotherapy. There's no risk of hepatosplenic T-cell lymphoma with the biologics. It's all with the azathioprine risk. Having said all that, there are a couple of studies that have talked about solid tumors. Again, no increased risk of solid tumors except for if you count it non-melanoma skin cancers, which definitely are increased in IBD. The question is why? Is it the drug? Is it other immune suppression? Is it ionizing radiation? And the patients have had CT scans, 75 times. So all those are potentially issues. Overall, my sense is there's no concern. I have no problem giving anti-TNF to people with breast cancer, colon cancer, prostate cancer, all the common solid tumors. But we've all seen some unusual rare tumors, sarcomas, other types of testicular seminomas and things that I sometimes wonder if they're infection-driven, if they're virally driven tumors, which some are. I sometimes wonder whether immune suppression has a role. But fortunately, they're quite rare events. And this is a reassuring study that actually, again, real world, that looked at people with cancer who were given biologic therapy, anti-TNF therapy for the most part, and didn't see a higher risk of recurrent cancer, even in people with pre-existing cancers of different solid types. So I think it's pretty reassuring. We have pretty good data now over many years that these are safe in this setting. This is a study that did show a slightly increased risk of cancer, solid tumors, but it was in the setting of combination therapy. So adalimumab plus an immune modulator, or thiopurines in specific, did increase the risk of solid tumors slightly. Absolute numbers were very small. These are relative risks. But adalimumab monotherapy did not. So again, combo with steroids always makes me nervous. I'm pretty happy with anti-TNF monotherapy as a safe treatment choice. I'm going to go a little faster. Just a reminder that the lymphoma risk, I know there's a lot of peds nurses here, and there's a lot of talk about azathioprine in younger males, but actually the biggest risk of lymphoma is to older patients. So over age 60, roughly, the risk of lymphoma starts to rise. in the general population. So I worry about immune suppressants and anti-TNFs in people over 60, and those are the groups you might want to think about other biologics or other therapies. I think we've talked enough about that. So in terms of reducing the risk, I say solid tumors, probably not a big concern, but try to avoid thiopurines where they're not necessary. Lymphoma, again, combination therapy where possible. Don't use it. If you need it, you need it. And you have to do a lot of risk-benefit assessment in that situation, and skin protection, obviously, for the non-melanoma skin cancers. The neurologic side effects are very rare, but everybody's seen a handful of demyelination, this multiple sclerosis type syndrome. It generally gets better when you stop the drug, although I have a few patients that have had residual deficits. So these are neuropathies. Again, the risk is really low. We're probably under, again, 1 in 5,000, but you do see it from time to time. A lupus-like syndrome is very rare, also generally not serious and generally gets better when you stop the drug. And this is a whole miscellaneous smorgasbord of other things that you can see, but maybe just to focus on the skin. They're very rarely serious and rarely require discontinuation, but you're going to maybe hear more about that later, but we've seen lots of eczema, psoriasiform reactions, and I've seen about 5 weird ones that I can't think of their names. I'm sure you know what they are, but pityriasis, this and that happen, and where the doc says, yeah, it's probably the anti-TNF, but we usually treat through it. And so it's rare that it requires discontinuation of the drug, but over the years now I've seen, I think about 20 or 30% of anti-TNF patients get some kind of skin problem. All right, in the last, let's say, 5 minutes, I'll try to cover the other ones. They're newer, so remember the caveat that I said, that everything I show you now is pretty limited to 5 to 7 years of data, a lot of it from randomized controlled trials, so we don't have enough real-world experience to be very comfortable with the full profile of these drugs. Having said that, I think vedolizumab, by its mechanism of action and the data, is probably the safest drug that we have. It is fairly targeted, although there's some speculation that we don't know fully how it works, but in general, the clinical benefit does seem to be related to its ability to prevent white blood cells from infiltrating the gut. Again, most of the safety data is limited to the registration trials. We don't expect to see serious toxicity, and I have not seen any serious toxicity. And so again, this is the what we call integrated safety data from all the RCTs, plus some available long-term extension trials. And if you look at just the adverse event rates and serious adverse events, the summary of it is the placebo groups had higher serious adverse events than the drug arms. And these are serious infection rates, which are generally, again, comparable, if not favoring the placebo group for infections. There's still, I think, controversy over the issue of C. difficile. I don't know if you believe that that's a higher risk, Niraj and Vedo, but the most recent large series suggested no increased risk of C. difficile with vedolizumab use. So I'm going to skip over those things because I don't have time, but just in summary, I think vedolizumab right now, for what the data is available, is probably the safest biologic, and it's by its mechanism and by the data available, and is maybe the most useful for those patients where you're worried about infection risk, toxicities because of other comorbidities. There's almost no contraindications to using it. Ustekinumab is the newest kid on the block, so it binds to interleukin 12-23 molecules to prevent that pathway from activating. By its mechanism of action and the way it's classed as an immune suppressant, you would think that it would behave similar to an anti-TNF, but in fact, again, so far it seems like a very safe therapy, maybe comparable to vedolizumab from what we know. It's used a lot by dermatologists, so a lot of the psoriasis experience has been used to show its safety. But we have to be careful looking at non-IBD patient populations to extrapolate safety, because I think psoriasis and RA patients don't have the same types of susceptibilities as IBD patients do. Having said that, this is some of the safety data that from the IBD population. Again, not showing any serious infections. And like I told you at the beginning, I usually just more or less disregard this type of data. But this is a combination with psoriasis patients that's integrated, that shows very low serious infection rates and comparable to placebo in the different populations. But you will note overall, like I said, the Crohn's population, just as a baseline, has higher serious infection rates compared to psoriasis. So just keep that in mind. So again, this is the Ustekinumab safety data, mostly from the psoriasis population that doesn't show any safety signals. And this is the malignancy risk across a number of biologics and psoriatic arthritis, showing Ustekinumab, again, very, very low. So far, Ustekinumab seems very safe, but it's still early days. And lastly, even earlier days, is JAK inhibitors, tofacitinib. So this has just been approved for ulcerative colitis in Canada. And this does, even in the registration trials, have some safety signals that we need to be aware of. Some of them are more concerning than others. There's been an increase in some laboratory parameters that we don't think right now have clinical relevance, like increased cholesterol profiles and elevated CKs. But at least from the rheumatoid arthritis experience, it doesn't seem to be clinically important so far. And then other signals that are most important is the herpes zoster signal. So you could see the risk in the trials was about 1% in placebo and the low dose tofacitinib, but in higher dose, 10 milligrams BID, the risk was about 5% of the patients, and that was a lot higher than the other groups. So it does look like there's a real zoster signal, and that's something you'd have to be aware of, whether it's in the kids population. The question is if they've had a chickenpox vaccine, they're probably not at risk of shingles, but for the older patients that have had actual chickenpox, they're the ones that we should be concerned about. You have to vaccinate them ideally before they start this drug. Having said that, although the signal is quite prominent, we've all seen shingles occur with all the other treatments that we use, including Azathioprine and anti-TNF drugs. Just it's a more prominent signal. The other thing with tofacitinib, although with all new therapies, we're a little reluctant to give it in women who might be considering pregnancy, that there actually is a specific warning about the duration after stopping tofacitinib before you should start trying to get pregnant of 4 to 6 weeks because of some teratogenicity data. So there's still, I think, maybe a bit more concern about using this drug in women considering pregnancy. And that's a whole other topic that we don't have much time. So to wrap up, and I'm sure that was a bit of a whirlwind. So I think the key, though, the whole package is, coming back to what I said at the beginning, is, choose patients properly. Don't give biologics or immune suppressants or potent drugs too late, but also not too early. You have to pick your patients properly. Don't do it when they have complications already. Say, oh, well, let's just try it to see what happens when they have a stricture or they have an abscess. Often patients need surgery who are very sick. So don't just try it just to see what's going to happen. Use it in the right patients. Make sure the patients are counseled. That's where you come in probably more than doctors, is, to tell them what to look for, tell them not to hesitate to call somebody if they're having a concern. Counsel them. I think if you really guide your patients, you can prevent disasters. A lot of the disasters are that the patient didn't tell anybody, they didn't know, and they just sort of sit around and nobody recognized a problem that had sufficient time. Avoid steroids and narcotics. And I'll stop there, and happy to have a little discussion about these issues. Are we just doing the Q&A from here? Okay, all right.
I want to thank you for a very comprehensive 1,000 drugs.
It's just getting more complicated as time goes on. We're going to have more and more therapies to talk about.
So I had a question about the paradoxical diarrhea associated with the 5-ASA therapies.
Yeah.
Is this associated with different brands? Because I know some patients, when you switch brands, they'll say, well, this causes more diarrhea than the other one I was on.
Yeah,
What is your experience with that?
So there was a 5-ASA whose name I'm blocking on that sort of disappeared from the market that had a much higher rate than all the others. Anybody remember which one? It started with a D. Dipentum, thank you. So dipentum, I haven't thought about it in years and years, but that one really had a higher rate of secretide. I think that's why it disappeared. But the others seem to be about equivalent, the other 5-ASAs.
Hi, thank you for the comprehensive review. You touched upon antibiotics. What is your approach with pouchitis in pregnancy, given that metronidazole is teratogenic, and also if you consider probiotics?
So yeah, it's a good question. So Cipro and metronidazole have gone through waves of sort of where they've been classed and how to use them in pregnancy. The current thinking is that they're generally okay. And again, everything in pregnancy is risk-benefit. So in pouchitis, we have a subset of patients that just nothing else works. So all I do is try to bring them down to the lowest effective dose, but I have continued people on both of them through their pregnancies. And I believe the current class of both of them is class B, so they're considered okay. So that's what I do. For probiotics are certainly safe if you can get somebody onto a probiotic. That would be preferable, but often you just can't. So.
Just a quick question on those patients in your practice who are over, say, the age of 55 to 65 on combination therapy with azathioprine, doing well, maybe you have them on it for immunogenicity. Do you stop it? Do you think about switching to methotrexate? Do you just go monotherapy? What is your approach?
Yeah, all of the above. I mean, I think I definitely have a conversation. I do have legacy patients on monotherapy azathioprine. They're now hitting 60, 65. I try to stop it. If they're on combo, I try to stop the immune suppressant. So I do have that proactive conversation. Again, it becomes risk-benefit. What do you do? If they have long-standing deep remission, I'll just stop them completely, because I do think some patients who've had 30 years of IBD and they've been in remission for a while, I think they flare less when they withdraw from therapy. But if I'm still worried about flares, then I will sometimes proactively switch to something else. And that something else right now is often Vedolizumab, because I think it's safer for the elderly patient population. But it might be that others will be okay too. But I do worry the most about Thiopurines and Methotrexate, and second most about anti-TNFs.
I just wanted to follow up. Just to follow up to Barbara's, how do you sell it to your patient? Because I find them very resistant if they've been comfortable on it for a while. They don't want to stop it. They feel great. They don't.
Yeah, I'm glad that you said it that way, because that's something I was talking to at the beginning. Is I don't try to sell anything. I'm not in the business of selling. I think your job is to present information and try to give them some balance, and I let them decide. You're right. There are patients who are very happy. They don't want to be touched. They've been in remission for a long time. They've had no side effects to date. And I actually don't think there's a cumulative increased risk of toxicity. Like, actually, those patients probably have fewer side effects so much later in their experience than the early patients. So I don't really try to push them. I just say, as you're getting to this age, there is a higher risk of lymphoma. Infection risk may be higher. How do you feel about your medication? Are you comfortable? Would you like to look at different options? I try to quote what I think the relapse rates are, which on average, let's say, is 10% per year, but might be higher depending on the situation. So it's just a discussion that I have. And actually, you're right. I would say more than 50% don't want to change their therapy, even though everybody asks when they can stop therapy before they go on. But the minority want to stop once they're on therapy doing well. So I don't really push it. I just have a discussion.
So Mark, be straight up with us in pediatrics. What do you do when a pediatric patient who's 18 transferred to you on combo therapy, infliximab and methotrexate? What do you do with that? Asking
So
for a friend.
I'll tell you the truth. You guys use too much of that stuff. The methotrexate. I mean, so we stop it a lot because the patients all come to us and they say, I really don't like the methotrexate. It's causing nausea. If they're on a needle, they hate that. So I actually end up stopping a lot of the kids when I see them stopping their methotrexate because they really don't like it. I think, in those patients, the pediatric community has been a bit too afraid of azathioprine and 6-MP because when patients are, the young patients are really sick with perianal disease or severe Crohn's, I think the benefits of the combo in that situation really outweigh the risks. And then you often do get them in remission because you guys are aggressive and you start their treatment. So when they come to me and they were diagnosed at 14 and now they're 18, they're in total remission, they have no active disease, it's easy for me. Then I might withdraw the azathioprine at that point because they've been in remission for years. So I do think that the ones that you send that are doing well, I'm often withdrawing therapy. Yeah, I think in general you do a good job with them, but they do not like methotrexate, I find in general. Once they're out of their parents' grasp, they express it more freely.
I have two questions. One is in regards to what you've just answered. Do you think you'll change your opinion based on the talk this morning that said that 40% of people have a genetic risk for developing immunogenicity against anti-TNF therapy in the absence of an immunomodulator? Until such time as maybe we can genetically test them. Does that change your opinion, or would it change your opinion if they've lost response to one?
Yeah, it's definitely different. To answer the second question first. If a patient's already had antibodies to a previous drug or they're on to their second biologic, I'm more aggressive about keeping them on combo because I think they're getting harder and harder to control. So that's a different situation. The testing, I'm not sold completely that I'd like to see, sort of another study or more validation of it. I'm not sure that it's going to be clinically useful just yet. I think it's complicated why people form antibodies beyond just genetic predisposition. But I think if we do have that test available, even if it's contributing some degree to our risk, I think it would be useful to have that information. So,
and then just one other question. I've had, actually in the last few weeks, anecdotal patients who are on Vedolizumab who are presenting with very unusual joint complaints. Are you seeing them?
Yeah,
How are you working them up?
Right.
And what are your thoughts about how to treat them?
Right. So that's a good question. That's starting to come up a little bit. I personally haven't seen that. I think you get more joint complaints with anti-TNF drugs overall. You're right, it might be a different sort of syndrome. I think, remember that vedolizumab is not systemically active. So the first thing is in patients who present with profound arthralgia, uveitis, pyoderma, I don't give vedolizumab in those patients. They get anti-TNF drugs. But what's, I think, happening, I think why some people are seeing that is they're a patient who was on a systemically active drug, whether it's steroids, immune suppressants, anti-TNFs, and they've lost response. Now they're going on a new drug, and so it's totally focused on their gut, and they're sort of getting the arthralgia or arthritis that they might have had anyways. So I'm not convinced it's occurring at a higher rate than you'd expect in a general IBD population, and that's what the data shows so far. So I've had a handful, but nothing to me that's been profound, nothing that's made me think I need to stop the drug. We've used some combo biologics in some of those patients, like vedolizumab plus an anti-TNF, and that it's expensive, but it's safe in my opinion. So I think there's different reasons why we might be seeing that phenomenon, but in our population of over 250 or so vedo patients, we really haven't seen that as a significant issue.
About antibiotics. What are your thoughts on using vancomycin in ulcerative colitis patients outside of CJ?
Right. So we do that probably more than others. I mean, we tend to get very complicated sick patients who've been refractory to a lot of things, and you're sort of struggling with ideas. So we probably do that in 5 or 10% of our UC patients. I have one patient in particular that is really kind of remarkable to me. He's a young, well, let's say 25-year-old male with UC that's failed Infliximab, failed Vedolizumab, and the only thing that ever controls his symptoms is vancomycin, and he takes it chronically, and he can dose. His stool frequency is exactly dependent on how much vanco he takes. And I'm nervous about him being on long-term vancomycin, but he happens to also be a physician, so he understands the risks, and he says that's the only thing that keeps him functioning. So I think there are subsets of patients that are very responsive to antibiotics, and it's, again, just a risk-benefit thing. And if you've tried other things and that's all you're left with, you do what you got to do sometimes.
So what about the dose then? I mean, we have had 2 patients, and there is one patient who takes, every second day, third day, and then her symptoms, like you're saying, symptoms increase, she'll increase it as well.
Yeah.
And,
Yeah, I mean, for hospitalized UC, we do often start it, and even if the C. diff's negative, we sometimes continue it. And for those patients, we use a C. diff dose, so like either 125 QID or 250 QID sometimes. And then in the ones that are the handful of patients that are outpatients that are using it, I, again, try to use the lowest effective dose. So sometimes it might just be, for that patient I was referring to, he uses 125 once or twice a day, and he thinks he can control his symptoms that way. And by the way, that patient doesn't have mucosal healing, so he's got active colitis, but his stool frequency is completely tied to the vancomycin, so it's kind of an interesting
So
situation.
we had one patient that had mucosal healing completely clean, like colonoscopy.
Yeah, I think that can happen. I mean, some of the patients do have a microbially driven disease.
Any more questions, anybody?
I've exhausted you.
It's okay. Thank you, Mark.
All right, you're welcome. Thank you.
Thanks very much, Dr. Silverberg. Thank you very much, Brenda. We're going to just take a brief refreshment break. We're hoping that maybe you could pick up your coffee and sweets and come back in here so we can get started by about 25 after 2. Thank you.